Thank you very much. Thank you for the kind invitation. I appreciate it a lot. We're going to talk about Iliac branch devices. Here are my conflicts of interest. And when we have an aneurysm of the common iliac artery, it is always the same question like this of Shakespeare, to be or not to be here, is to exclude or not to exclude the hypogastric artery. Well, we have good guidelines about this issue, and we have the guidelines from the European and the American Society, and it is clearly recommended that blood flow should be preserved to at least one hypogastric artery in the course of open or endovascular aortic repair. So the question is, if we have to preserve at least one hypogastric artery, what should we do with the other one? If not, if we were not using an iliac side branch device also for the second one, we have some data about the way that we have to exclude the hypogastric artery. This is a nice paper published this year with a systematic review and meta-analysis of the effect of hypogastric artery exclusion. 61 studies were included, and they classified the results by the type of the exclusion, by the location of the exclusion, and by the side of the exclusion. The great analysis showed that the quality of evidence was very low. However, we have some clear messages. The first one, regarding the type of the exclusion, they found that direct coverage, despite the risk of type 2 endoleak, the reintervention rate were very low, and plugs were actually the most optimal treatment. The coils led to very high rates of buttock-claudication and erectile dysfunction. Regarding the location of the exclusion, as proximal as possible, you see the difference between proximal and distal exclusion, and regarding the side of the exclusion, that is exactly what this outcome reflects. Also the guidelines, bilateral exclusion is associated with very high rates of adverse events. So my running conclusion about the type of the exclusion of hypogastric artery, it's if it should be done, if you have to exclude it, do it as proximally as possible, and either use plug or direct cover the hypogastric artery. So the question is how to preserve the hypogastric artery. We have different treatment options been published: the sandwich technique, the Nelix technique, the hybrid procedure, the aortouniiliac endograft with a crossover bypass and a Viaband from the external to the internal iliac artery, and of course the standard iliac and traditional iliac side branch device. I'm not going to talk about the first four treatment options because all of them are off-label combinations. So regarding the iliac side branch devices, we have at the moment three available endoprostheses. One of them has the FDA approval, and this is the Gore device. The first one is the well-known Zenith devices, the ZBIS. It is a 20 French device. We have different modifications with spiral legs, straight legs, bifurcated endograft. We have the new device from Gore, the excluder iliac branch devices. Is a low-profile device, 16 French with a preloaded wire, and we have here, that is a real nice feature, we have a dedicated bridging stent graft for the internal iliac artery, and we have also the e-iliac in Europe. This is from a German company, Jotek, very similar to the ZBIS with some difference regarding the very proximal diameter. So regarding the data and what this data teach us, regarding the ZBIS device, we have, let's say, this is the best investigated device in the world. We have numerous papers about the devices and different papers about durability. I use here and present here the last one. This is from Cleveland Clinic, where I investigated 72 patients with a mean follow-up of 41 months, and they were able to provide 10-year outcomes. The technical success was 97%, and overall morbidity of 8%, and you see freedom from AAA-related mortality at 10 years, 99%, freedom from type 1 and 3 endoleaks and 10 year, also 99%, but we have some kind of secondary reintervention. The freedom was about 81% and 10 years, and if you look on details about this issue, you will find that we had problem with the primary patency of the iliac side branch devices. At 10 years was 77%. However, in this paper, the majority of the patients were investigated by an ultrasound, and let's say by obese patients, maybe this will be a little bit challenging. On this issue and regarding the patency of the ISB endograft, we have a very current paper from Europe, the so-called pelvis registry. We were able to also to include our patients inside. 6 European countries, 650 IBDs. This is really a big cohort. A mean radiological follow-up with CT, with angio-CT, 30 months. Here again, very high technical success rate, 98%. Overall occlusion rate, 2%. And you see that the freedom from hypogastric artery occlusion at 8 years years was 95%. However, from common and external iliac artery occlusion, 87%. Probably that is the problem with the patency of the ZBIS. And we have a freedom from type 1a endoleak about 94%. The majority of these patients were isolated ZBIS. So the authors concluded that poor landing zone in case of isolated IBDs is a risk factor for type 1 endoleak, and elongated external iliac arteries is the main risk factor for occlusion of the external iliac artery. On the other hand, we have the excluded ISB endograft. This is a very new device. We have the great registry from Europe and the prospective multi-center study from the US, 63 patients, 28 centers. The protocol here said that you have to at least to use it for one hypogastric artery and then to occlude the other contralateral side. What the authors found was a technical success of 95%, primary patency at 6 months, 95%, no batoclaudication, no type 1 and 3 endoleaks. However, we have to wait about 5-year follow-up. We had now to the during the Weissschule annual meeting in San Diego the 1 and 2 years results with really excellent patency rates. Regarding the e-iliac ISB endograft, we have one study. This is a retrospective multi-center study, 70 patients from 6 centers in Germany. Here the median follow-up was 12 months, and again, very high technical success rates of 100%, no adverse events. We had some problems, or they had some problems with type 1a endoleak at 1 year in isolated iliac side branch devices, and the freedom from occlusion at 1 year was 92%. The question is now, you have 3 devices, which one shall we use? And we have a nice paper published in Annals of Vascular Surgery regarding the applicability of the devices. They compared the ZBIS devices. You can also, the same design is also the e-iliac to the excluded devices regarding the conformability to different anatomic scenarios. And what they found was that the excluded IBD was more conformable than the Cook ZBIS in patients with severe iliac tortuosity. This was defined by an index 1.14. This I can confirm the same result, because this is also my strategy now in Schatz tortuous external iliac arteries. That ZBIS will not have a good performance regarding the external iliac artery, so the excluder will be a real, or it is a real nice solution. Now I'm going to talk for 2 specific scenarios. The first one is the aneurysm of the hypogastric artery. For the majority of the IFUs and also for the physicians, it is an exclusion criterion. For us, it is not. We have already published our experience with the exclusion of those internal iliac artery aneurysms. Here is the way we're doing it. We're using an Advanta stent graft and a Viaban, and then we're doing a relining with a bare metal self-expanding stent. We're using mostly the superior gluteal artery as our target artery, and then we're embolizing all the other branches in order to avoid a type 2 endoleak. This kind of technique led to a primary patency at 2 years of 95%. And this is real nice results by 3D reconstruction. The second important scenario would be a type 1b endoleak or an aneurysm post-EVAR of the common iliac artery. And here we have published our results in 18 consecutive patients. Here you have to keep in mind to repair something like this, you have to use a transaxillary approach or transbrachial approach. I prefer the transaxillary approach and the transfemoral approach. And here the technical success was 100%. It is really nice to go from above. Primary patency of the hypogastric artery was 100%. Keep in mind here, the majority of the endografts, they have a limb of more than 12 millimeters. So in order to repair it with the ZBIS devices, you have to use a 16 millimeter limb from the Endurance. This is the ETLV 1616, C82 or 93, just a technical tip. Summarizing, and my take-home messages for this issue is that if you have to exclude an hypogastric artery, I told you try to do as proximally as possible and use plug or direct covers, but try to preserve at least one. All ISB devices showed excellent rate of technical success. It is actually a device that can be implanted very nicely and safely. The ZBIS devices, it is the only device with a proven long-term efficacy, but we have no prospective studies. The excluded ISB is really conformable in tortuous iliac vessels, and in my opinion, the device of choice, but we have only midterm proven efficacy, and the e-iliac showed promising 12-month results, but we need some more data. The aneurysm of the hypogastric artery is, in my opinion, not an exclusion criterion for ISB devices, and at the moment, based on our experience, ZBIS is the device of choice for the treatment of type 1B endoleak post-EVAR. Thank you very much.